بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good evening everybody. To our friends and colleagues in the field of nephrology. The Saudi Society of Nephrology is happy to introduce another webinar to them. This webinar will be a very interesting subject. We will call it Advancing Frontiers in CKD Management and Optimizing the RRSA therapy to put in our mind the potassium level. My name is Ahmed Mitwali. I think most of you know me. I'm the founder of this society, and I've been honored to give this introduction. Professor Stock from Limerick, Ireland, is a professor of medicine nephrology, and our moderator is our colleagues and our son, Professor Faisal Mahayani. I will give the floor to Faisal to give the introduction of the professor and to start the lecture. Thank you very much indeed.
السلام عليكم ورحمة الله وبركاته. السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ahmed. Good evening, everybody, and welcome to the first virtual meeting in our series of virtual meeting under umbrella of Saudi Society of Nephrology. And I will thank all supervisor and coordinator who create this work in these not good days. And thank you again to give me this opportunity to be the supervisor and coordinator of this work. As Professor Ahmed mentioned, as you know, the renin-angiotensin aldosterone system inhibitor, like for example ACE inhibitor, are commonly used in clinical practice. How in clinical practice? Because of their benefit in reducing proteinuria, treat hypertension, and also it's proved to reduce cardiovascular morbidity, and also approved to reduce mortality. However, because of the risk of hyperkalemia, which seems to be a major obstacle that most of us, especially nephrologists, when we are treating the patient with chronic kidney disease, especially in the later stages of chronic kidney disease. So we put this in our mind, and most of the nephrologists, as I believe, they try to avoid it. However, although we have certain medication that can reduce potassium and can optimize us or allow us to use these type of drugs, like for example diuretics or calcium or sodium resolum, but because of the lack of efficacy and presence of serious adverse effect, it seems to be it is not a good option. So today the questions: do we have another modality that can help us to optimize use of RASI inhibitor and gain all benefit of this medication without aware of hyperkalemia? We'll see. Today, on behalf of Saudi Society of Nephrology members, I would like to present Professor Austin Stack, which is a professor which is a nephrology consultant at University Hospital of Limerick in Ireland, who is interested in management of chronic kidney disease complication, and he will talk today about new volunteers in optimizing use of renin-angiotensin aldosterone system inhibitor through better potassium control. And Dr. Austin, the mic is with you. Yeah, sorry, Dr. Austin, at the end of the talk, we will we'll open discussion and we'll receive questions. And you can ask through press the icons at the bottom of the screen. By pressing the icons that mentioned by large capital Q and A, and you can create your questions, and we will try to answer most of the answer if the time allows us. Dr. Austin, the mic's with you.
Good evening, everyone, and thank you very much indeed for inviting me to give this talk for the Saudi Society of Nephrology and Transplantation. I'm delighted and I am honored. And thank you for the introduction. So colleagues, this evening, what I would like to share with you is really some of the challenges that we have in 2020 at optimizing kidney outcomes for patients who have hyperkalemia and also progressive chronic kidney disease. If we think back, I think we will all agree that the abnormal or dysfunction of the renin-angiotensin system is a principal driver for chronic kidney disease. And whatever the cause of chronic kidney disease, it is that final common pathway. And it leads to, progressive intraglomerular hypertension, progressive glomerulosclerosis, albuminuria, and ultimately progressive kidney disease and kidney failure. And one of the obstacles that's currently preventing us from using RASI therapy or increasing the dose of RASI therapy, particularly in those most vulnerable stage 4 and 5 CKD patients, is hyperkalemia. So this evening, I'd like to address some of those issues, and I look forward to having an excellent dialogue with yourselves. In terms of the presentation, I'm going to focus initially at hyperkalemia, why it's so important, and what does the evidence show in terms of its link and association with major clinical outcomes. I will also reiterate the benefits of inhibitors of the renin-angiotensin system use that many of you are very familiar with. And then I'm going to focus on some of the consequences of either not using or underdosing with RASI inhibitors on patient outcomes. And certainly there's emerging data that informs us that if we don't optimally treat patients with either an ACE inhibitor or an angiotensin receptor blocker, then those patients are likely to have poor outcomes. And finally, we'll talk about some of the barriers to RASI use. And then in the latter part, I will focus on novel mechanisms to manage hyperkalemia and so that we can enable greater use and optimization of RASI dose in patients with advanced kidney disease. So many of you will be aware that as kidney function declines, that there's a greater propensity for hyperkalemia. And if you look at population-based studies, and if you stratify them by GFR, with progressive chronic kidney disease, the curve moves to the right. So you have a greater proportion of individuals with hyperkalemia and with serum potassium values in that higher range. If we choose, for example, a threshold potassium of 5.5, we can see that the lower the GFR, the greater the likelihood or the burden of hyperkalemia. And this is data from the CKD Prognosis Consortium, which shows almost a linear relationship between worsening kidney function and the prevalence of hyperkalemia. If you look at the health system where you and I work, there is definitely a very strong relationship between worsening kidney disease, worsening stage of CKD, and the burden of hyperkalemia. This is data here from the Irish healthcare system, which we just presented at the recent EDTA meeting that was held virtually in June. And it demonstrates that as your GFR declines, the prevalence of hyperkalemia increases. And just to point out, for example, in patients with CKD stage 4, the prevalence is about 30%. It rises to about 50% in patients with CKD stage 5, and that is using a very conservative threshold of a potassium over 5. If we're more restrictive in our definition of hyperkalemia and use 5.5, we see a very similar pattern, even though the magnitude or the prevalence is somewhat lower. And then again, I mean, looking at stage 5 CKD, we have a prevalence of about 35 to 30% of patients will have hyperkalemia in the healthcare system. If you look at clinics where patients come and get managed by nephrologists like you and me, there is again very strong data that the prevalence or the frequency of hyperkalemia is quite substantial. Whether you look at mild, moderate, or severe hyperkalemia, you can see with worsening stages CKD, the prevalence increases. This is very nice data from an Italian group that analyzed data from over 2,500 individuals that they've been prospectively following at their clinic. And look what happens about a year later when they come back to clinic. You're seeing almost an identical a pattern of hyperkalemia with worsening kidney function. The burden of either mild, moderate, or severe hyperkalemia increases. There is now quite strong evidence, certainly from an epidemiological perspective, on the association of serum potassium and mortality. And what we now know, as you can see in this graphic, that the relationship is not linear, it is U-shaped. And that means the higher the serum potassium, the greater the risk of death, and the lower the serum potassium, also the higher risk of death. And it's quite a U-shaped correlation. It tells us that both hyperkalemia and hypokalemia are not good for patients, and really draws us to focus on what should be the desired normal range. And importantly, for patients with CKD, it looks like the risk of hyperkalemia on death is far greater than individuals in the general population. And so if we look at this graphic, and I think it's important to spend a couple of minutes on this, when we look at the risk of death associated with different levels of hyperkalemia, if you go from normokalemia to severe hyperkalemia, you will see an increasing trend of mortality. We see it across all stages of CKD from stage 3 to stage 5. But I'd like to draw your attention to the fact that if you look at stage 5, the magnitude of difference between mortality in the normal range to the severe hyperkalemia, it's about a 3-fold difference. Whereas in stage 3, the difference is about 15-fold. And that would suggest that the impact of hyperkalemia on mortality is far worse for patients with mild kidney impairment versus those with advanced or severe kidney disease. So in our meta-analysis, which we presented a couple of years ago at the European Renal Association, where we analyzed data on several 100,000 patients who had serum potassium levels measured and had the outcome of mortality. And what we wanted to do was analyze the association between serum potassium and death in patients on dialysis and those who are not on dialysis, the so-called non-dialysis CKD patients. And if you look at the green graphic here, the green bars here, you can see there's a somewhat of a U-shaped association for those on dialysis. In other words, high potassium is not good and low potassium is not good. But if you look then at the red bars and the red graphic, you will see that the magnitude of the risk is far greater. It's at least 1.77 times greater for patients with hyperkalemia, and it's almost 4 times greater for patients with hypokalemia. In other words, there's a risk difference or a differential risk, which implies that having a high potassium is much worse for patients with mild CKD versus those on renal replacement therapy. Switching gears slightly, just to focus our minds again back on the renin-angiotensin system. So many of you will remember from your medical school days that the renin-angiotensin system plays a huge role in glomerular filtration, renal perfusion. However, there is a maladaptive component that happens over time such that unregulated or dysregulated activity of the renin-angiotensin system leads to progressive glomerular injury. And in this little schematic here, as many of you will know, it's that increase in intraglomerular pressure that's mediated by that excess vasoconstriction by angiotensin II that causes progressive intraglomerular hypertension, progressive pressure, and ultimately proteinuria. This is what we want to prevent. And our colleagues 30 years ago did sentinel work in terms of evaluating the efficacy of the ACE inhibitors and the angiotensin receptor blockers in their ability to control blood pressure, improve heart health, improve kidney health, and prevent worsening kidney function. So we know these drugs are beneficial. Indeed, just to remind ourselves, we are very familiar with the landmark trials in diabetes, the ACE inhibitor trials. I remember in 1993, I had just qualified about 2 years, and Edmund Lewis presented his study on type 1 diabetes and found that captopril delayed doubling of the creatinine, and it protected patients from progressive diabetic nephropathy. And this sentinel observation, this sentinel trial was replicated by others, demonstrating the efficacy of the ACE inhibitors to protect against progressive diabetic nephropathy. Soon after, we had results from the RENAL, the IRMA2, and the IDNT, and all these clinical trials collectively demonstrated that if you block the angiotensin receptor with an A or B compared to patients not on that drug, you will get a stabilization or a reduction in the progression of chronic kidney disease. And in fact, if you look at it in more detail, the data suggests that it's not just being on the drug, but it's being on an optimal or maximum dose of the drug that leads to that benefit. And in this graphic here, we have shown some of the clinical trials and the drug doses and their ability at reducing albuminuria and the gain in terms of improvement in renal outcomes. And what it shows is that the greater reduction in albuminuria with higher doses, the greater renal benefit. And this is hugely important. So national bodies, international guideline groups, professional societies have recommended ACE inhibitors and angiotensin receptor blockers for the prevention of chronic kidney disease. And this is not the soft recommendation, this is a class 1A recommendation. And they advocate that these patients should be on the highest tolerated doses in order to slow the progression of kidney disease, reduce proteinuria, and protect against progressive decline in GFR. Despite those recommendations, and despite the evidence over 20 to 30 years, when we look at the utilization of RASi inhibitor therapies in CKD patients, we see an underutilization of those across all CKD patients, but particularly in those with advanced CKD. And this data from the DOP study, published by Dr. Picot's Filho just last year, analyzed data from over 5,000 individuals from the CKDOPS cohort. And if you look at Brazil, France, Germany, or the United States, you will see relatively underutilization of ACE or A or B therapy or combination therapy that actually increases or worsens with advancing level of or advancing stage of CKD. So that tells us that we have an issue, we have a problem in managing patients with advanced CKD who should benefit most, we think, from these RASi inhibitor therapies. One big question is, what will happen patients if we stop their ACE inhibitor or their angiotensin receptor blocker if they have advanced CKD? And this is a question that we all face in our clinic. And sometimes we have patients whose GFR is, down to 25 mils a minute, their potassium is 5.7, and we say, let's stop the ACE inhibitor or the angiotensin receptor blocker because we can't manage the hyperkalemia. And this study by Keogh et al. Published just this year analyzed the risk associated with discontinuing RASi inhibitors versus not discontinuing in patients with CKD when their GFR fell below 30 mils a minute. It was a fairly large cohort, would follow up for 5 years, and the outcomes they analyzed were quite substantial: mortality, major cardiovascular events, and end-stage kidney disease. And this is what they found. So when they looked at mortality, they found that the incidence of mortality was far greater in individuals who discontinued the drug than who continued. And you can see here the survival curves. No matter what way you look at the data, the survival is worse for patients who discontinued therapy versus those who continued on treatment. The mortality is, as you can see on the screen, the hazard ratio was 1.39, meaning that individuals who discontinued therapy or individuals who had their therapy discontinued had a 39% higher risk of death than those who did not. When they looked at major adverse cardiovascular outcomes or events, they found almost an identical pattern to mortality. Again, the outcomes were worse for patients who had their treatment discontinued. In fact, it was 35% higher than individuals who did not. Again, suggesting that stopping the ACE or the ARB therapy in individuals with advanced kidney disease is not a really good idea and doesn't bode well for patients. So one issue is if patients get their therapy stopped. What about patients who are on what I would call a submaximal or suboptimal dose of RASi inhibitor therapy? One of the questions is, how common is it? And secondly, what does it mean in terms of outcomes? And this is a nice study from Epstein and colleagues from a large healthcare organization in the United States, who looked at the dose of individuals of their RASi drugs, either the ACE, the ARB, after they had died. They looked back retrospectively and found out what dose were they on. And what they found, if you look at CKD patients 3 and 4, that only 42% were on a maximal dose, and up to 54% had had their dose stopped. Similarly, for heart failure and diabetes, there's a similar pattern. In other words, individuals who die tend to have a lower dose prescribed or a lower maximal dose prescribed of a RAS inhibitor therapy. Similarly, when they analyzed the association of the link between the RASi dose and the risk of death, they found, and I think you will agree with me, across stages of CKD, even among heart failure patients, diabetes, that individuals who had the maximum dose of RASi therapy had the lowest mortality. Those who had a submaximal dose, again, had a higher mortality, and the mortality was highest among individuals who had their treatment discontinued. Again, this would fuel the argument that to really get the best outcomes in terms of mortality, that individuals, certainly in the CKD program, should be on a maximum dose of therapy versus a submaximal dose of therapy. So the construct of this lecture this evening is, can we optimize RASI therapy by improving potassium control? And as somebody said a number of years ago, yes, we can. So I do think the time has come in 2020 when we have new novel medications that can allow effective control, allowing us or enabling us to maximize or optimize the dose of inhibitors of the renin-angiotensin system. So I'm going to focus on two of those new drugs in the next few slides. And the first drug is called Pateramer. The actual name is Pateramer sorbitex calcium. And this is a non-absorbed cation exchange polymer. It's indicated for the treatment of hyperkalemia. It's given orally. It binds potassium in the colon, and it exchanges potassium for calcium. It's designed to be fully ionized at the physiological pH of the colon. And it has been tested in at least 2 clinical trials, phase 2 trials, in terms of the efficacy at lowering serum potassium and its safety profile. The first trial, and I won't go into the trials too much, but I think it's important that you have, we have visibility on the trial design and its construct. The first is the OPAL-HK trial, published in the New England Journal a number of years ago. This was a phase 3 clinical trial that tested the efficacy of Pateramer in lowering serum potassium in patients with stage 3 or stage 4 CKD who were on RASI therapy and whose serum potassium levels were between 5.1 and 6.5. Now, that's quite a range from mild to moderate to severe hyperkalemia. And the primary outcome for this patient clinical trial was the change in the serum potassium after 4 weeks. This trial had 2 component parts, a phase 1 and phase 2. So in the initial trial, patients were randomized either to Pateramer or a placebo. And prior to that, they were stratified by either mild or moderate hyperkalemia, where mild hyperkalemia was defined as a potassium between 5.1 and 5.5, and moderate between 5.6 and 6.5. The mild hyperkalemia group were treated with a Pateramer on a dose of 4.2 grams twice daily, where the moderate to severe group got a higher dose at 8.4 grams twice daily. They were followed for 4 weeks, and their serum potassium levels were then measured. The second part of the trial was equally interesting in that individuals who were originally moderate to severe hyperkalemic and then who had a good response were subsequently randomized to either continuing the Pateramer or being randomized to placebo. In other words, it assessed the sustainability of Pateramer in keeping the potassium at a normal level. And for that phase 2 trial, the primary endpoint was at week 4. Again, the change in serum potassium, and there were secondary endpoints at week 8 in terms of the proportion who had good potassium control and the proportion who remained on a RASI inhibitor therapy. So this is the efficacy component of the trial. And as you can see, going from left to right, after the initial 4 weeks, individuals randomized to a Pateramer therapy, the overall group, irrespective of their potassium level, the average fall in serum potassium was about 1 millimole per liter. The reduction in serum potassium was far greater in those with moderate to severe hyperkalemia than those with mild, which I'll show you in a few minutes. And in the second part of the trial, those who were randomized to Pateramer continued to have a normal or normal serum potassium, while those who were randomized to placebo, the serum potassium gradually increased, and the difference was 0.72 milliequivalents per liter. So then this again here, the slide illustrates the primary outcomes. And as I mentioned, the overall benefit or the overall effect was approximately 1 millimole per liter reduction in serum potassium, irrespective of the group. But those with moderate to severe hyperkalemia had a greater lowering of serum potassium by minus 1.2 millimoles per liter, when those who had mild hyperkalemia, it was somewhat less at 0.65. Interestingly and importantly, those individuals, those patients who were enabled to stay on the RASI therapy because of normalization of the serum potassium, there was quite a big differential between the Pateramer arm and the placebo arm. Among patients who remained on Pateramer, 94% were continued to receive RAS inhibitor therapy, whereas only 44% of the placebo, in other words, 56% that the drug had to be discontinued. Similarly, only 16% of the Pateramer arm required any adjustment in RASI therapy, where 62% of the placebo arm. In other words, normalization of serum potassium allowed more flexibility in continuing the use of RAS inhibitor therapy, which, as we know, is associated with significantly better clinical outcomes. The second trial I'd like to mention is the Amethyst DN trial, which again was a more complex study that it evaluated both the long-term efficacy and safety of Pateramer, in addition to trying to determine the optimal starting dose for individuals. And in this clinical trial, individuals who had, again, a fairly advanced stage 3, stage 4 CKD, they were diabetics with albuminuria. All patients were on a stable RASI dose, and they all had mild to moderate hyperkalemia. And the primary outcome, again, was a change in the serum potassium level. It was quite a complex trial, and anytime I look myself at a slide like this, I get confused. But basically, after the screening, individuals were randomized either to the Pateramer in successively increasing doses, and stratified by hyperkalemia at baseline, mild between 5 to 5 and 5.5, and moderate between 5.5 to 6 milliequivalents per liter. In addition, at the outset, 3 cohorts were constructed to reflect different clinical approaches and different medication scenarios. So, for example, cohort 1 were patients who discontinued their RASI therapy. They were starting losartan, and then if their blood pressure was elevated, you could add spironolactone. Cohort 2 were allowed to continue RASI therapy and then add spironolactone 25 milligrams daily. Again, these are important because nowadays, as you will recognize, we're not just using one RASI drug, we're using a combination, certainly for some patients with CKD and for many patients with heart failure, as you will be familiar with. So the population, the average age was 66 years. The serum potassium in the mild hyperkalemia stratum was 5.2, and the moderate was about 5.7, 5.8. And you can see the distribution of CKD stages, that they were quite evenly distributed across stage 3, stage 3B, and stage 4. And this is what happened following randomization. You can see that there's a nice drop in serum potassium fairly quickly after about day 3. So this drug works fairly quickly. And then there's a sustained, potassium levels are sustained within the normal range at about 4.6 until the end of studies when the medications are discontinued. Interestingly, that irrespective of the degree of the hyperkalemia, it looks like in the mild and the moderate, they both find an eventual stable baseline at about 4.6 millimoles per liter. When they looked and analyzed the serum potassium effect by starting the dose, there is somewhat of a dose response. In other words, individuals on the lower dose had the least benefit, and those who were on the 16 or 25 gram had the greatest benefit in terms of serum potassium lowering effect. The pattern was quite similar at week 8 as it was for week 4 of the study. So that was Pateramer, one of the new potassium binding agents. The second new kid on the block is SZC, also called sodium zirconium cyclosilicate. It's a mouthful. And this again, it's unlike Pateramer, it's a sodium-based potassium binder. It's selective. It selectively binds potassium in exchange for sodium. And unlike Pateramer, the sodium zirconium cyclosilicate works along the entire GI tract. It is a more rapid onset of action, but again, it has some side effects like GI intolerance, hypokalemia, and importantly, edema, which may be important in patients with advanced CKD when you want to prevent and treat volume overload. The principal trial, or one of the principal trials that tested the efficacy of SZC was the harmonized clinical trial. And this was a randomized clinical trial that analyzed the efficacy of sodium zirconium on reducing serum potassium levels among outpatients who had both CKD, diabetes, and quite a high proportion also had heart failure. Patients were hyperkalemic at study entry, and of course they were all on RAS inhibitor therapy. And of course patients who were on dialysis or had reduced life expectancy were excluded. There was 2 phases to this study design. The first was an open label phase where they assessed the efficacy of a 10 gram 3 times a day dose in achieving normokalemia in the initial recruitment or screening phase. And if patients achieved normokalemia, they were then randomized to one of 3 doses of the drug, a 5 milligram, 10 milligram, and 15 gram dose versus the placebo. These are the results which you can see on the screen. Compared to the placebo group, you are seeing an impact on serum potassium levels. They are kept within the normal range. We can see a dose response effect. In other words, the 15 gram dose has a greater effect, and which was significant in lowering serum potassium than the 10-5 gram dose, and indeed compared to the placebo. So as would I expect, that sodium zirconium cyclosilicate is effective at normalizing serum potassium among patients with hyperkalemia on existing RASI therapy. One of the side effects that I mentioned is edema, and this occurred certainly in the high dose SZC group. So in the placebo arm, it was 14%, and it increased from 7% to 9% with increasing dose of SZC. The other side effects, as could be expected, were hypokalemia and GI intolerance. And in the longer follow-up phase, there's good evidence now that SZC is effective at normalizing serum potassium and keeping it within the normal range for a prolonged period of time. And this is the 12-month phase 3 study, which you can see on your screen. So one thing, of course, one of the challenges, what happens in clinical trials may not be replicated in the big bad world, in the real world. And at the moment, we don't have a lot of data with regard to these new drugs, both Pateramer and SZC. And this is just a very recent publication by Kovetsky and colleagues who looked at a very large healthcare organization, the VA database in the United States. And it put it, at least, even though the numbers are small, it does suggest that patients who are treated with this drug, that they get a significant lowering of potassium either at 1 month or 3 months post treatment. And you can see the delta change, again, is very like the clinical trials, about 1 millimole per liter. So the big question is what's next? So we now have 2 new novel potassium lowering agents. We have small clinical trials that have tested their efficacy and their safety over fairly short periods of time. And what they've shown to us is, number one, that they can significantly lower serum potassium. They can keep it within the normal range. They appear to allow and enable a higher dose, and in many cases, an optimal dose of RAS inhibitor therapy, but we don't have all the evidence next at the moment in terms of their clinical use and their efficacy in clinical populations. So in terms of where we're going, I think it's important to really look at their use in clinical practice. But while we're doing that and evaluating them in real time, I think it's important that we have hard outcome data. And there's 2 large clinical trials that have just started. One is called the Diamond trial, and the other is the Prioritized HF trial. And these are hard outcome clinical trials that will test the efficacy of both Pateramer and the sodium zirconium cyclosilicate in patients with heart failure, with major hard outcomes like cardiovascular death and cardiovascular hospitalization. So the Diamond trial is recruiting 2,300 individuals, and the proposed date of completion is March the 31st, 2022. The second trial is the Prioritized HF trial, and I believe that is up and running at the moment. The completion date was October 2020, but as you know and I know, due to the current global pandemic, due to COVID-19, many things have been delayed, and certainly clinical trials have become more difficult to implement and to complete. In summary, colleagues, I would like to say that hyperkalemia is extremely common in patients with chronic kidney disease. The frequency and the burden increases with worsening kidney function. Hyperkalemia is associated with substantial morbidity and mortality. Part of that might be mediated through potassium itself, but part might also be mediated through the underutilization of RAS inhibitor therapy. There's evidence to suggest that we know this, that RAS inhibitor therapy elevates serum potassium levels. And we do know that guideline recommended RAS therapy is prevented by evolving hyperkalemia. And I suppose from our perspective, the fear of worsening hyperkalemia in CKD patients. And that's why we typically, either stop the medication or reduce the dose of the medication so that they don't run into potassium problems. We've got 2 novel therapeutic agents to add now to our armamentarium, Pateramer and SZC, and these are effective at lowering serum potassium. They offer better tolerability and safety over existing therapies. And I believe, and I suppose we hope to show that in our clinical trials, that these would enable optimal doses of RAS therapy in order to improve patient outcomes. We look forward, of course, to ongoing clinical research, and we certainly look forward to the completion of those 2 big clinical trials. And with that, I would like to thank you for listening to me. I'm here in the University of Limerick in Ireland in my office, and it's quite strange to be talking virtually to the Saudi Society of Nephrology from my office, when normally I would have wished that I was actually attending there in person. So thank you very much.
Faisal, can you allow me to say one thing? I should thank Few for Pharma for their contribution. They are the one who's supporting this lectures. Thank you very much again. Thank you, Faisal. Please, the floor is for you. فيصل افتح الصوت.
Thank you very much, Austin, for this nice and informative presentation. And we gain from this lecture that we can maximize use of RAS inhibitor since we have this novel GI exchanger. So now I will, if you don't mind.
فيصل الصوت عندك مشوش وبعيد شوي، قرب لما المايك. افتح المايك يا فيصل وقرب جنبه لانه صوتك مش.
Now it's clear.
جو هيد بس مشوش برضه غريبه، ما ادري ايش غيرت، كانت الامور كويسه. في Go ahead.
So thank you, Professor Austin, for this nice presentation. So we gain from this lecture that we can maximize use of RAS inhibitor, and we can gain all benefit of using RAS inhibitor since this introduction of this novel drugs. So only the questions regarding these drugs. Did those new study was done and focused on patient with, for example, a patient with end-stage renal disease or patient with kidney transplantation? As you know, those patients, especially the last group with kidney transplantation, they are receiving many drugs. So as a nephrology transplanter, so I'm afraid from the drug interaction and the action of those drugs. In addition to that, I knew that these drugs can cause hypomagnesemia, and hypomagnesemia itself can be induced by the calcium inhibitor, and you know the complication of low magnesium.
Thank you, Faisal. I just say that you weren't coming through very clear, so I want to make sure that I get the gist of your question. I think one of the questions was, to what extent have these drugs been examined in dialysis patients and kidney transplant recipients? Now, I'm aware there are some studies either starting or ongoing to evaluate the efficacy of these drugs in those very important cohorts. You're absolutely right. I think what people would feel from a clinical or scientific perspective is to first of all examine and test the efficacy of those in those non-transplant, non-dialysis stage 3, 4, and 5 CKD. I think that has been the focus initially. But I do believe, as we kind of move forward, that dialysis patients should potentially be recruited, and certainly transplant patients, because even in our own clinical program, I do know that they run into problems with hyperkalemia, either because of coexisting medications, many of them are diabetic, and many of them, as you know, have different degrees of graft dysfunction. So what I would say is, I think they need to be studied. The second issue I think you mentioned was with regard to hypokalemia and hypomagnesemia. And I do believe that, Pateramer can cause hypomagnesemia, but for most patients who've got advanced kidney disease, low magnesium levels usually are not a problem. Typically the magnesium tends to increase. I don't think that is going to be a big issue, but certainly from the safety and efficacy studies that have been published to date, the risk or the rate of hypomagnesemia was quite low in those particular studies. But what I think going forward, I think the large clinical trials, which 2,000 or 3,000 individuals, will tell us more about the safety profile, which I think is extremely important with both of these clinical drugs.
Austin, I received a nice questions from Dr. Abdul Ghamdi. So he's asking about the long-term consequence of using Pateramer, since as you mentioned about Pateramer, it will exchange calcium for Mortality. So is it associated with increased risk of chronic calcium risk profile? we're supposed to check the calcium level, and is there any major adverse regarding the cardiac and cerebrovascular event?
Yeah. Could I ask you, Fazal, the reception is not great in your microphone. I can't really hear that question well. I apologize. Now, I don't know, maybe one of your other colleagues might.
We'll try to help. Faisal, can you switch off your phone if you have a cell phone? If you are not using cell phone, switch it off. Probably this is the one interfering with your mic.
I think now it's solved.
There is a problem with your mic, definitely, with no doubt. We cannot hear you very well.
Okay.
Are you using laptop or mic or your phone?
I'm using the laptop.
Laptop. So you need to close your iPhone or any cell phone near to you. Switch it off.
Okay. Now,
maybe better.
So only regarding the chronic use of Pateramer, is it increased risk of cardiac and cerebrovascular event, since it may increase level of hyperkalemia, and if it's associated with hyperkalemia, so we supposed to check the coronary calcium risk profile? These questions I get it from Dr. Abdul Ghani.
Fazil, I was able to make that out. So you're making a great effort, even though the microphone is an issue. So I think the question revolves around issues of hypercalcemia with the use of these agents. And to my knowledge, calcium problems are not an issue. So I don't think there's any major disturbance in serum calcium levels. The only electrolytes that are affected with these agents from the studies presented and published to date are potassium, so it can cause hypokalemia, and magnesium, hypomagnesemia. I don't believe it affects the serum calcium levels per se, but like that's the data we have from both the OPAL HK and the harmonized clinical studies. But again, I think going forward, you're absolutely right. When we test these strategies, particularly when we're using a potassium binder that can affect other electrolytes as a longer term strategy, we need to look at those closely going forward. And I hope that the questions that you're asking will be addressed appropriately with those longer term clinical trials. Because as you know, with those phase 3 clinical trials, the overall function of those is, number one, to test efficacy and confirm it in terms of heart-term outcomes. And the second is to ensure that they're safe for patients. So we don't want to give a drug if it's going to cause something really bad, like you said, hypercalcemia or coronary calcification. But from my understanding so far, that is not an issue from the published clinical studies.
Okay, the questions I received from Dr. Muhammad Abdul Qadir regarding the price or cost using these novel GI exchanger compared with carbon Zirconium. Is there any huge difference?
Fazil, are you talking about the cost of drugs, the cost of the medication?
The cost.
The cost.
The money.
The money.
Yeah.
Okay.
Yeah.
I don't have the exact data on the cost. I'm just trying to figure out. I did see something there from the UK. Let me just check for a second in terms of cost. Yes, I'll give you some of the data on the cost. So in the UK, I don't have data from Ireland, but at least from the National Health Service in the UK, the cost of the drug for 130-gram sachets is, you know, that's the 8.4 grams, it was 172 pounds. And the National Institute of Health estimate that the cost of implementing it as a therapy is about £5,000 per 100,000 of the population. And that'll rise to about £15,000 per 100,000 by the end of 2023. Well, I don't really know what that means, but let me put it in context. When we're talking about the cost of the drug, I would say the cost should be evaluated with regard to the health cost in terms, and the economic cost in terms of outcomes. So what's the cost of dialysis per year? In most Western countries, and it might be the same in Saudi, hemodialysis costs about 70,000 euros per year, or maybe $80,000, you know. So I think the cost has to be weighed up against the cost of preventing end-stage kidney disease, preventing hospitalizations from progressive kidney disease, and from cardiovascular events through the, if you enable the use of brachytherapy. So I think it's hard to kind of make a full evaluation of the relative cost effectiveness of the drug at this time point. You know, I don't know how it compares to sodium polystyrene sulfonate, whether it's more cheaper or more expensive, but I think that is something that needs to be looked on once the clinical studies are done. I think the first thing we need to do is get the clinical trial data on the outcomes, demonstrate if they're better, if they're superior than existing therapy, and then we can look at the cost model, because if something prevents kidney failure by allowing RASI use, or prevents a major cardiovascular event by normalizing potassium, you know, I think the cost might be well worth investing in that medication.
Thank you again. And I believe this is one of the last questions. Regarding zirconium, as you mentioned, it will increase the sodium load. So, and you know, there are many patients with chronic kidney disease that may be related to heart problem or may be related to liver disease. So, is there any contraindication to use this type of drugs in those types of population?
Yeah, Fazil, thank your colleague for that question. That's a really important question, and I don't have all the answers at the moment. Again, I think we need some of the longer, you know, clinical trial data with the bigger trials. But you're absolutely right that of those agents, you know, SZC tends to cause edema and maybe predisposing patients to volume overload, unlike Pateramer, which does not cause edema. So in patients, for example, who've got heart failure or patients with advanced CKD with progressive overload, the decision would need to be made, well, if you're going to put a patient on those drugs, do you need to up the dose of diuretic as well, or do you need to start them on a diuretic? Alternatively, you might say, you know, if I have two drugs, one causes edema, the other does not, then it might be more prudent to use the drug that doesn't cause edema. What we don't know at this time point is whether that edema has any significant impact, clinical impact, on either renal function or cardiovascular function. As you know and I know, many drugs can cause edema. The calcium blockers that we use every day, you know, can cause lower extremity edema. But whether the edema is because of a big sodium load that could adversely affect the patient's total volume status and put pressure on the heart, I think we need to get some longer clinical trial data on that.
Thank you very much. Thank you very much. And thank you again to the Society of Nephrology members to organize this valuable